Let's talk about deep tendon reflexes. Do you feel confident performing them in neurological exam? What does it mean if they are either diminished or increased? In this video, I will try to answer these questions. Okay, let's start then with the biceps and brachioradialis reflexes. The biceps and brachioradialis reflexes are mediated by the C5 and C6 nerve roots. The biceps tendon can be palpated in the antecubital fossa. If you are struggling to feel biceps tendon, you can always ask patient to flex their forearm. By doing that, the biceps tendon should become more apparent and you should feel something which reminds a thick cord. Once the biceps tendon is identified, make sure that the arm is completely relaxed, forming an angle of slightly more than 90 degrees. Patient can be either seated, then the arm rests in the patient's lap, or lied flat on the back and then the arm rests on the patient's torso. The biceps reflex is elicited by placing your thumb on the biceps tendon and striking your thumb with the reflex hammer. You should then observe the forearm moving upwards. Let's have a look at video and see how it's done. Next, the brachioradialis reflex can be tricky to elicit as the tendon cannot be well seen or palpated. We need to remind ourselves where brachioradialis muscle is located. Looking at the scheme, we can see that it's on the lateral side of the forearm that articulates with the wrist on the thumb side of the hand. Hence, to elicit the brachioradialis reflex, we are aiming for an area located about 10 cm proximal to the wrist. Again, patient can be either seated, then the arm rests in the patient's lap, or lie flat on the back and their arm rests on the patient's torso. Before striking this area with your reflex hammer, make sure that the forearm is completely relaxed. In normal response, the forearm will flex at the elbow and the palm will turn upwards. Let's have a look at video. Next one, the triceps reflex, which is mediated by C7-C8 nerve roots. The triceps tendon is a broad structure that can be easily palpated. It's located on the back of the upper arm and extends from the elbow to the body of the triceps muscle. Sometimes, if there is a lot of fat tissue, it might be tricky to find it. We can ask patient to extend their forearm at the elbow so that tendon can be felt better. Once the tendon is identified, we place the thumb and strike the triceps tendon with a reflex hammer. Patient can be either seated or lie flat on the back. When the patient is seated, we need to gently pull the patient's arm out from the body such that it forms the right angle at the shoulder. When patient lies flat on the back, we need to place patient's arm on their torso in the 90-degree angle. Before striking the tendon with a reflex hammer, we need to make sure that the arm is relaxed. A normal response will cause the forearm to swing away from the body. Let's see how it's done. Now, we will talk about lower limb deep tendon reflexes. The first one, the knee reflex, also known as patellar reflex, is mediated by L3, L4 nerve roots. The patellar tendon connects the kneecap to tibia. If it's hard to identify patellar tendon, we can ask patient to extend the lower leg so the quadriceps muscle will contract and make patellar tendon more apparent. The patient can be either seated or lied on the back. If the patient is seated, the lower legs should be dangling over the edge of the exam table. If the patient is in supine position, we need to support the back of their thighs with our hands such the knee is flexed and quadriceps muscle relaxed. When we strike the patellar tendon with a reflex hammer, the lower leg will extend at the knee. Let's see the video. The second one, the ankle reflex, also known Achilles reflex, is mediated by S1, S2 nerve roots. The Achilles tendon runs from the heel to the muscles of the calf. This structure is very easy to identify, but if you are struggling or unsure, you can ask patients to put their foot down or to pretend to press a gas pedal with their foot. In this way, the calf muscles will contract and make Achilles tendon apparent. Patient can be either seated or lied on a back. If patient is seated, we need to make sure that feet are dangling over the edge of the exam table. If patient is in supine position, one leg should cross the other, such that it forms a figure 4. A normal reflex will cause the foot to go down. Let's have a look at video. We've just briefly talked about deep tendon reflexes and how to perform them. Now let's talk about how to interpret them. Deep tendon reflexes are often rated according to the following scale, from 0 to +5. 0 means absent reflex. +1, trace or seen only with reinforcement. +2 is normal. +3 is brisk. +4 means no sustained clonus. +5 means sustained clonus. Deep tendon reflexes are normal if they are +1, +2, +3, and they are not asymmetric. Reflexes rated as 0, +4, +5 are usually considered abnormal. By saying that deep tendon reflexes are abnormal, we mean that they can be absent, decreased, or increased. Deep tendon reflexes may be diminished by abnormalities in muscles, neuromuscular junction, joint disease, sensory neurons, lower motor neurons, and in some systemic disease. For example, patients with diabetes with time may develop peripheral neuropathy, which will prevent or delay the transmission of the impulse to the spinal cord. In result, the deep tendon reflexes will be diminished or completely absent. On the other hand, the deep tendon reflexes may be increased if there are an upper motor neuron lesions. For example, in traumatic spinal cord injury or in patients with stroke. It's worth mentioning that usually immediately following such injuries, the reflexes are diminished and then after a few weeks, reflexes are increased.